Charlotte DiStefano is a clinical instructor in the Semel Institute, and she's going to talk about outcome measures in children. And she's been if I understand this correctly, she'd been a special ed teacher at some point, but has a PhD with Connie Cassery, who is the director of the treatment program in our center, and then followed by a postdoctoral fellowship in kind of biomarkers with Dr. Geste. And so I'm really looking forward to hearing her speak about this, because I have not heard this particular talk from her before either. So we're all going to learn a lot. Thank you.
All right, hello. As Dr. Geschwin said, I started out my career as a special education teacher, and then I did my PhD in intervention research here and have recently transitioned over to doing biomarkers research. And so what I'm going to be talking about today is sort of some background and introduction for Dr. Geste's talk about our biomarkers research. And so what I'm going to be focusing on today is how we think about outcome measures in any sort of trial for autism, whether that's a behavioral intervention study or a drug trial, and some of the challenges to coming up with good outcome measures in these trials. So I'm going to go just quickly over some of the structure and assumptions that we make about clinical trials, and then I'm going to talk about challenges to how we choose the right outcome measure for a trial, focusing specifically on the heterogeneity within ASD and how that presents some big challenges for us, choosing outcome measures that are going to be sensitive to change, challenges stemming from the placebo effect, which has been mentioned in a couple other talks. And then, because my focus is particularly on the minimally verbal end of the spectrum, I'm going to talk about how some of these challenges really magnify when we're thinking about that portion of the spectrum. So in general, when we think about treatments for autism, we provide intervention, either behavioral or pharmacological treatment, based on whatever the presenting symptoms are. And then in a clinical trial, we choose some set of outcome measures to try to quantify how our treatment changed those symptoms that we were targeting in the first place. In terms of what we target in trials for autism, you've heard a couple people already talk about the core symptoms of autism versus some of these associated comorbidities. And so our treatment trials might be directly trying to address core symptoms of social communication and restricted and repetitive behaviors, or they may be addressing some associated symptoms and comorbidities like anxiety, ADHD. And so the outcome measures that we choose are hopefully going to be specific to which symptoms it is that we're trying to change. I'm going to talk about randomized control trials, which hopefully a lot of you are already familiar with, but just to make sure we're all on the same page. A randomized control trial is a really important concept in study design. We want to make sure that the results we're seeing are really valid and representative. And in a randomized control trial, we have a whole bunch of participants that participate in our trial. We randomly assign them to one of either two treatment conditions or a treatment and a control condition. And that random assignment is really important to make sure that we can really trust the results that we get. And then we measure outcomes in both of those groups. And if our treatment group has different outcomes than our control group, then we conclude that that's likely due to the impact of the treatment that we provided. In terms of treatments for autism, for quite a while, the mainstay of intervention research in autism was the single subject research design. Which is common in behavioral research, and that's where a lot of the original research for discrete trial training comes from. But the field has really moved towards using more RCTs and more rigorous study design. This is a graph from a recent review just showing the frequency of RCTs. So you can see up till about 2010, there were very few, and then in the time since 2010, there's been a huge increase in the number of randomized control trials that have been conducted in ASD. And then really exciting, there's been more interest in innovative study designs, for example, SMART designs, which Dr. Goldstern is going to talk about more this afternoon, which are a specific type of RCT that helps us build and test adaptive interventions. So just in terms of study design, the field is moving much more towards these rigorous study designs that will help us really understand what works in terms of treatment. But we still have quite a lot of challenges. And you heard in Dr. Schneider's talk earlier a lot of drug trials in autism that have been considered failed trials, that, you know, we put all the effort into doing these studies and then didn't get the results that we were expecting from them. Some of that might be because the drug really didn't work the way that we expected it to. Some of it might be because we have to be very careful about how we design and implement clinical trials in order to make sure that we're really measuring the things we think we are and that we can draw the conclusions we expect to. So these are sort of the components that we can think about. So as I go through my talk, I'm going to be thinking about it in this framework. We have some sort of intervention or drug that we're providing, and we hope that our intervention or drug is actually hitting whatever target we have selected. But that's sort of our first logical assumption, right? We assume that if we're using a medication that targets some particular component of brain chemistry, that it's actually targeting that. That assumption may or may not turn out to be true. In terms of our selection of participants, sometimes a study may choose participants that are the wrong age for that intervention or drug to work very effectively, or we may end up with a selection of participants that are too variable, too heterogeneous for us to be able to tell if something is working really effectively. And then in terms of our outcome measures, there are all sorts of challenges to choosing an effective outcome measure. We may choose an outcome measure that ends up being too subjective. It's too based on, for example, parent report. And then we're going to have maybe a really large placebo effect. Sometimes in an effort to overcome that, we may choose an outcome measure that's too general or non-specific, which is going to reduce our ability to find meaningful change, to really measure variability between participants. Heterogeneity within ASD is a huge challenge to any sort of research study. We have to decide what proportion of the ASD population we're going to include in the study. ASD, as you've heard from all of our talks, is a really diverse group of kids and adults. It's not a single disorder, it's a constellation of symptoms that all fall into the same category of ASD. We're starting to understand a lot more about the genetics and neurobiology, and we know that there are a lot of different etiologies and pathways that lead you to have ASD characteristics. And this is a really big challenge in trying to figure out who we're going to recruit into trials and how we're going to be able to interpret those results. If we decide to restrict the participant pool, that might increase our chances of finding significant results, but it then reduces our ability to generalize those results to the whole population. On the other hand, if we choose a participant pool that is too variable, we may not end up being able to figure out who that intervention works for and why. Careful participant characterization is really crucial to make sure that we know who has been included in these different studies so that we can compare across studies, replicate those studies, identify things that might be moderating treatment. So I'm going to be talking about things in the context of outcome measures and measuring the outcome of a treatment, but we also want to think about these measurement issues in terms of just describing who the participants are and what their abilities are like. So some questions to think about when we're figuring out what we want to measure. What skills are being targeted in this trial? Are we trying to address the core symptoms of ASD? Do we think that's really what's going to change? Are we targeting some associated symptoms like anxiety, which is prevalent in ASD but not specifically a core feature of ASD? What do we think is meaningful change? And I'm going to come back to this topic at the end in reference to minimally verbal kids. But what do we think constitutes meaningful change in the participants that we're including and in the time frame? we need to think about if a study is going to run, for example, for 12 weeks, what is going to be meaningful change within that 12 weeks for the type of participant that we've selected? And then what measures are available? There are measures that are going to focus specifically on some very proximal intervention target. Can I get a child, for example, to vocalize more often or to say more words during the session? That's a very proximal target. Versus looking at something like that child's overall cognitive test score. That's going to be a very distal target of intervention. In this same recent review that I showed you the graph from, French and Kennedy looked at 48 different RCTs that have been published in autism, and in those 48 RCTs found 87 different outcome measures. So the field is definitely not agreed on a specific set of outcome measures. Part of that is because these studies are targeting different portions of the ASD population and targeting different symptoms. But that, of course, makes it difficult to look across studies and try to compare the types of effects that we're seeing, since our outcome measures are all different. There's a range of domains that we can assess and that these RCTs have assessed, looking at core symptoms of autism, looking at cognition and adaptive skills, and then global scales of improvement like the CGI, which I'll talk about in a minute. And then, of course, we always have the issue of balancing parent-caregiver report versus direct assessment. The type of information that you're going to get from parent-caregiver report is, of course, going to be representative of that child across their day, throughout their life. And we can get information that we can't get right there in the testing room. But at the same time, there's going to be a lot more subjectivity, bias, possible placebo effect in a parent-caregiver report versus a standardized direct assessment that we do with the child. So balancing those two things is really important. I don't know how well you guys can read this, but this was a nice little figure from this, again, the companion piece to that same recent review. Just trying to break our outcome measures into these proximal versus distal measures and how we can think about this. And they were thinking particularly about early childhood interventions, where we often have a parent and a child together in intervention, and so that's the dyad that they're referring to. So in that context, we can look at the specific behaviors of the parent and the child during the actual intervention session, or if it's with an interventionist, the interventionist and the child during the intervention session. And we can look to see if those things are changing, and that, of course, is a very proximal intervention target. We can also look at the child behaviors outside the context of the dyad, but still looking at pretty proximal variables. So if we do an intervention that's targeting joint attention, and then we do an assessment that looks at joint attention between the child and an assessor, is the child then showing more joint attention skills in that assessment setting outside the context of intervention? And then there are really distal measures that look at the impact of that intervention over time on things like autism symptoms, cognition, adaptive behavior, and are these really global skills showing that they have changed as a result of intervention. I think a nice example of this comes from Connie Casseri's work on JASPER. Again, Dr. Goldschred's going to talk about this much more, so I'm not going to go into the details, but I just wanted to highlight this contrast. So what I have up here first is a study of 61 minimally verbal participants who were in an RCT treatment study. And in this case, the kids were in intervention for 6 months, and then we did a follow-up 3 months later. And in that time frame, we saw really nice differences, really nice growth by using the language sample, which on our graph would fall into that pretty proximal targets, but at least outside the intervention context. So in an assessment context, but not a standardized global measure of language, specifically a natural language sample, which Connie Casseri and others developed for use with this population. And we saw that kids in one of the interventions were using more words at the end than kids in the other intervention. In contrast, Dr. Goldsrud and Connie Kazari looked at a 5-year follow-up from what had been a 6-week intervention. So a very short-term intervention, but now they were looking at the kids 5 years later to see what the impact of that intervention had been. And at that point, they were able to find differences in a standardized global measure of expressive vocabulary. Those differences probably wouldn't have been salient yet at just 6 weeks after they'd finished the intervention, but it had put those kids on a different trajectory that then we could measure with a standardized assessment 5 years later. So that's just an example to highlight the importance of thinking about what type of measure is going to capture the change we expect to see within the time frame of this study. Okay, let's talk a little bit about the different assessment domains and how we measure these things. In terms of looking at the core domains of autism, we can do a direct diagnostic assessment. The most common assessment is the ADOS, the Autism Diagnostic Observation Schedule. However, the ADOS is really not designed to detect change. If you read closely, a lot of studies will look at the ADOS pre and post and try to see if kids have changed, if those scores have changed. But that's really not how the ADOS was designed, and it's not great at detecting change. It's meant to be a much more stable measure of core autism symptoms over time. There are also parent report measures like the SRS and the RBSR, in which the parent just sort of goes through a checklist of a bunch of different characteristics and rates whether or not their child matches those characteristics. And those are a little bit better at being able to detect change, but of course we have the subjectivity problem with the fact that they're parent ratings only. Recently, the Kathy Lord's group, the same group that developed the ADOS, has developed the Brief Observation of Social Communication Change, the BOSC, which hopefully we'll start to see used in trials a little bit more often now. And this is really based on trying to observe similar things to what is scored in the ADOS, but in a way that's going to be more sensitive to change and is scored from just a 10-minute parent-child interaction. So hopefully that measure we're going to see more often in clinical trials as opposed to the ADOS moving forward. Cognitive and IQ measures, and I'll lump standardized language measures into this category as well, are really better for looking at long-term change. They're not very sensitive to short-term change. We're not likely to see a big change in a child's IQ score from a 6-week intervention study, for example. In autism, we have to be careful about whether or not we want to look at verbal IQ or nonverbal IQ. Those tend to be more discrepant in kids with autism than they are most of the time. A lot of our kids have higher nonverbal IQs than verbal. So we need to be careful about choosing which one of those we think is going to be more likely targeted by our intervention and make sure that we're measuring the right one. For our kids who have more profound impairments, we often have floor effects, which means that the child just can't even perform on the assessment, and so we don't even get a valid score for them. In the early years, kids who are under 5 and particularly up to about age 3, there's a lot of instability in these scores. And so we want to be careful that what we're measuring, if we see change in a child, for example, who's 2 years old, we want to make sure that that's really true change and not just change in how well they were able to follow directions and be able to participate in the assessment. Some of the same problems with adaptive behavior assessments. We see a lot of floor effects, kids who just can't even attain the first score on the assessment, and so we have nothing to report. A lot of these we get from parent reports, so again, subject to bias. Sometimes we have interview and questionnaire discrepancies, where if we ask the parent to just fill it out on their own, we get one set of answers. And if we actually interview and talk through the questions, we get some different answers. Which I think just has to do with how they're thinking about the questions and how they're thinking about their answers to them. And again, these are going to be relatively insensitive to short-term change. Dr. McCracken showed that example of one of the studies where I believe it was the folic acid study, where the authors concluded that they had seen change in communication, but looking at the Vineland measure of communication, there wasn't a change. And that might have to do with the fact that we're not likely going to get change on this type of global standardized measure in such a short period of time. And the clinical global impression, CGI, is something that you'll find in a lot of clinical trials, where a clinician who hopefully is blind to the child's treatment status, which group they're in, makes an overall numerical rating of how severely impacted is this child by, for example, their social communication deficits. And we can look to see if that clinician sort of expert overall rating changes with intervention. One more thing I want to highlight. This is a really neat study that was published by Kathy Lord's group looking at the placebo effect. And in this study, they actually didn't do any sort of intervention or treatment. They just brought kids in and asked parents the same questions time 1 and time 2, and they were following the kids regularly in between. And the parents were rating the kids as much improved at the second visit compared to their ratings at the first visit, while the clinician who was doing a blind rating of the child did not see any improvement over that period of time. And there wasn't even any treatment to really have a placebo effect in this case. It was just the impact of answering the questions over and over again and really thinking about those things. And so we have to be careful about how we account for the placebo effect when we're dealing with clinical trials. All right, a couple things to highlight when we think about how this then applies to minimally verbal kids. So minimally verbal kids are somewhere between 20 and 30% of the ASD population. Certainly some of them have intellectual disability, not all of them do if we look at just nonverbal IQ. And there are a lot of associated neurogenetic syndromes where we see a high comorbidity with ASD, and these kids often tend to be minimally verbal. And when I say minimally verbal, these can be kids who have no language at all, or kids who have some single words and short phrases, but they're really limited in how they're able to use them. That's why we use that phrase. All right, so one quick video to highlight a cutie pie from one of the studies that I showed you results from earlier. This kiddo was just over 5 at the beginning of the study. Not using really any communication in our first language sample.
Giraffe. Giraffe. Big ball, please. Big ball, please. Snowman. Snowman. And then snowman. Snowman. And then snowman.
So we would consider that meaningful change for him. His standardized test scores didn't change at all over the course of that study. But if we code the language sample and the language that he's using in it, I would conclude that's pretty meaningful change to go from not really communicating at all to using words and short phrases for a variety of pragmatic purposes. The question is, do we all consider that meaningful change? And if so, how are we going to characterize it? So when we think about our kids with minimal language, we're a lot more likely to see floor effects. There's limited sensitivity for how these measures are going to be able to measure their skills across different participants and over time. And then we have to think about the impact of language on other domains of assessment. I'm about out of time, so I'm just going to say quickly, in terms of floor effects, you'll notice this is a group of kids with duplication 15q syndrome. Most of them have ASD as well. And we see big clusters of participants at the bottom of these graphs, right? That's our floor effect right there, where we're not getting any difference among those participants. And then finally, we need to think about if we're measuring other domains, do those measures rely on an assumption of verbal language? So for example, the social responsiveness scale, which I mentioned before, a lot of the questions are asking about social behaviors, but in order to answer the question, the child really needs to have language, and so the parent's not even sure how to answer it. The same with the CBCL, which is another common measure, and we see similar problems. Feels or complains that no one loves him relies on an assumption of having verbal language to even express that idea. All right, so that takes us to the end. So Dr. Juste now is going to talk more about how biomarkers can help us address some of these challenges that we see with clinical outcome measures.
Thank you.